ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರ. ನನ್ನ ಹೆಸರು ರಂಜನಾ ಅಂತ. I am Ranjana Kalburgi, member of Citizens for Citizens or C4C, and I welcome you all to this fourth episode of C4C Conversations. C4C is a platform for concerned citizens, and our aim is to leave our surroundings a little better than we found it. We take up various subjects and interface closely with other citizens, government officials, people's representatives, media, etc. to bring about positive changes. C4C has various groups or subcommittees handling different subjects of interest to the citizens. Example, solid waste management, traffic, public transport, deforestation, street lights, etc. We are happy that in about 1.5 years, C4C has already done a lot of good work, but yes, we still have a long way to go. C4C Conversations is a monthly program wherein we bring experts in various relevant fields to enlighten us. The first program by Uday Kumar was on the journey of Bengaluru from Antarctica to 16th century CE. This was followed by the presentation by Yashashwini Sharma on Bengaluru's Pete and Kote, which means markets and ports. The third C4C Conversation program was by Shri Venkatesh on waste segregation and eco-bricks. In the same series, today, we have the fourth episode of C4C Conversations on a very apt subject, which is directly connected with the present pandemic situation. So we all know that coronavirus affects various organs in our body, but lungs are its prime target. So we have today's speaker, Dr. Srivatsa Lokeshwaran, whose expertise is about our lungs. He will educate us regarding the present pandemic and its effect on our health, as well as make us understand better about how to prevent infection transmission and protecting the elderly. We also need to know how to be a caregiver to those who are already infected. He will also touch upon what lies ahead of us in terms of what should we expect and the status of vaccines of virus. Let me add that during this presentation, all the audio from the attendees will remain on mute so as to avoid any disturbance. You are free to mute your video also if you so desire. So at the end of the presentation, Dr. Srivatsa will take a few questions. In case you have any questions while the presentation is going on, kindly use the chat part on the screen. So depending on the availability of the time, Dr. Srivatsa will take up the questions. So I request you all to pay full attention, and even if we get few good tips, you will definitely end up taking good care of yourself. At this point, I request Rajkumar Dugar, founder and convener of C4C, to give a brief introduction to Dr. Srivatsa. And later, Dr. Srivatsa will take over. Over to you, Raj.
Thanks, Ranjana. ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರ ಮತ್ತೆ ಈ ಕಾರ್ಯಕ್ರಮಕ್ಕೆ ಸುಸ್ವಾಗತ. Are you able to hear me?
Yes.
Okay. Let me start with a disclaimer. Introducing a doctor, especially a specialist, is not easy for a layman. I have given introductions of several doctors, including Dr. Devi Shetty, and believe me, it is not easy because of the many medical terms and tongue twisters required to introduce them, which are not easily known to ordinary folks like us. Similar is the case today, but I'll try and keep it as simple and brief as possible. Dr. Srivatsa Lokeshwaran completed his MBBS from KIMS, Bengaluru in 2009 He proceeded to complete his MD in pulmonary medicine and then did his fellowship in respiratory and critical care medicine at National University Hospital, Singapore, and followed it up with fellowship in respiratory endoscopy at the National Cancer Center, Japan. He is presently pulmonology consultant at Aster CMI Hospital, Bengaluru. Pulmonology, as many of you may be aware, is a study of the respiratory system, which mainly includes the lungs. Dr. Srivatsa is trained in advanced airway and pleural procedures. Pleural, not opposite of singular. Pleural is to do with the membrane which covers our lungs. But I am not qualified and will not take the risk of clarifying any more medical terms that follow. So, pleural procedures like thoracoscopy, EBUS, tumor debunking, stenting, and bronchial thermoplasty. He has completed MAP, BIP, and certified IP fellowship in advanced interventions like rigid bronchoscopy, complex central airway pathologies, cryotherapy, laser, and endobronchial valves, etc. Well, I told you it's not going to be easy to introduce a specialist. Dr. Srivatsa runs an interstitial lung disease or ILD clinic, one of the very few in the country to have a comprehensive ILD multidisciplinary group and conducting regular academic activities in ILD every year. He is also part of Asthma and Airway Disease Clinic at National University Hospital, Singapore, along with other experts in the field. And he has been running an asthma clinic in asthma phenotyping and advanced therapies for asthma. Of course, needless to say, Dr. Srivatsa has been invited to give talks at various national and international forums and has also several publications in numerous peer-reviewed journals to his credit. And today, we are indeed lucky to have him speak on this, the fourth episode of C4C Conversations during the COVID-19 pandemic caused by SARS-CoV-2 virus. All of us know by now that this virus has a great affinity for our lungs. And so who better to educate us on handling this than an expert on our lungs? I have tried to keep away difficult terms in this introduction and I have consciously kept it brief since I'm sure you're more interested in hearing him. So sit back and use this opportunity to get empowered to take care of yourself better. I welcome Dr. Srivatsa Lokeshwaran and request him to take over now.
Thank you, Mr. Rajkumar, for that very kind introduction. And let me just start my screen share first. So good evening, everyone. I hope you can all hear me well. Can you?
Yeah.
Yeah, great. So, so today's topic is about COVID-19. So this is a very relevant topic, he says, but I think this is the only thing we have seen through 2020, unfortunately. So what's COVID-19 and how does it basically, affect our life and brought about this sudden disruption of our daily living all through the world? So I've aptly titled it as Learn to Breathe Your Way Out of COVID-19 in the present pandemic, because there's always a way out of the mess we are presently in. Now this particular image, if you all can see on your screen, talks volumes about our very, understanding of existentiality and how the human species that has been ruling this world for many decades and fluxing its powers in various different aspects could, be brought down in such a short time to its knees by something that is such a small particle which is not even visible on a regular microscope. So this shows how frail our existence is and how fragile it is, and what Corona has taught us is nothing new. So this was in Beijing railway station. As you can see, there are health workers who are going around trying to sanitize the railway station. This particular image I'm showing you is another city, Hong Kong, not too far off. And this basically represents how people are accustomed to the new way of life. In fact, for the last 10 months or so, I seem uncomfortable without the mask than wearing the mask. So definitely we have gotten used to this way of living. And this doesn't seem new for us at the present moment. So, but what this picture exactly talks about is how easy it is for a particle to travel from one town thousands of miles away to another city and cause havoc by spreading. And this is the basic concept of a pandemic. So this particular hotel, which I'm showing you, was occupied by one particular doctor called Professor Lu, who's a professor of medicine, and he stayed in this hotel called Metropolis, unassumingly on the 9th floor at room number 11. And it seems that this 911 seems to be a bad number for all of us and has been associated with a lot of previous devastating occurrences. But I will leave the conspiracy theories aside. But this doctor basically carried the pneumonia right from Beijing all the way to Hong Kong. And subsequently, this virus spread wild in the community. They had to cordon off a lot of people, and it did cause a lot of death, as you are all aware. So this COVID rhetoric, which we are all hearing for the last 1 year or so now, so we are almost completing a year in another couple of days, doesn't seem to be new. Why? And have we even learnt our lessons from what happened in the past, is what we must ask ourselves. So this is not exactly the COVID pandemic, the images I showed you. It is something similar that happened in the year 2003, and this was called as a severe acute respiratory syndrome. And this is one such zone where such patients were managed at our capital in a super specialty hospital, where you see doctors in a dress very similar to the present age, with their N95 mask on, gowns on, with strict precautions to prevent the spread of this pandemic. But lucky we were that this was contained very soon and didn't cause much damage. So there was about 8,096 people who were infected in 2003, and it caused about 774 deaths. And what you see below that is the image of the SARS-CoV virus or the coronavirus. So the coronavirus gets its name from the crown-like appearance it has, as you can see. And the present SARS-CoV-2 virus, or the edition 2 of the previous virus, is nothing similar to the previous virus because it is being genetically mutated. Only thing similar is that it derives its origin from a similar host, that is the bats. So I will talk to you more about that in the subsequent slides. So the SARS-CoV-2 virus, basically, as we all know, was a deja vu for most of the medical community, because the initial infection was contained to a large extent in Southeast Asian continents. We didn't hear much about it in India, though there were a couple of cases. And the first case, like you're all aware, happened at WUHAN in China. And it was first brought to the notice of the WHO country office on 31st December 2019. And on Jan 11th, we lost our first patient due to the novel coronavirus. So the disruptor, as you see, is very similar to its previous cousin, the SARS-CoV virus, has a similar crown, and has definitely proved devastating, as you can see, taking many lives every single day until today, and continues to do so. Not sure how many more it is going to take. Once it struck Wuhan, there was an emergency exercise, which is very familiar with us because we know what they do with the previous airborne pandemics. The whole Wuhan market was closed because of the present pandemic. About 41 cases of unknown viral pneumonia, or clusters as we call it, was reported to WHO, and it was trying to be contained. But I'm not going to comment on the efforts and go into various aspects of that. But what you see here is the Wuhan market being sterilized. And this is the point, or what we call ground zero of the pandemic. The impact the pandemic had was manifold. It was debilitating. It left many people stranded in a developing country. People didn't know how to react. They'd never seen anything like this, and their livelihoods tanked because of the significant socio-economic impact that a health issue could have at this large scale. And this was a domino effect. Not only it affected healthcare, it affected various other aspects of our life that we didn't imagine that it can affect. And so did it affect the developed countries, with people stranded in large cruise boat ships for about months together. Here you can see the diamond ship, the Diamond Princess, basically docked at Yokohama in Japan, and people stayed in there for months together, with food being supplied from outside, primarily because of containment efforts. So the pandemic basically caused havoc. So how has COVID-19 changed my life? So this is what I go through almost day in, day out for the last many months. Wrap myself up in 3 layers of clothing, and breathing through a very tight mask, preventing ourselves from getting affected by the virus. So when I say that I wasn't prepared for it, I really mean it. Little did I know that many years later, after finishing my graduation in pulmonary medicine, there would come a circumstances of only the fables I've heard from my previous predecessors or professors who have had the chance to serve in the SARS-CoV era. And let me tell you, the experience has been moving, and it has taught me a lot about life and how things can change overnight, and how we must all persist to live our present. So what the WHO basically did was to declare an emergency, because the pandemic started crossing borders, affecting countries after countries, continents after continents. And there's only been about 6 times the WHO has declared emergency in the past. One was the swine flu, which you're all aware of. And then later came the re-emergence of polio. Polio was a disease which again I was involved, in curtailing during my medical days. And we were very happy that polio had been eradicated. And it re-emerged in 2014, which was quite a scare for us. Subsequently, we had the Zika virus, which was a mosquito-borne transmitted virus in 2016. And then again, a mosquito-borne virus in most of Africa called the Ebola virus. And mind you, the Ebola virus is much more deadlier than the present coronavirus. And then came the SARS-CoV-2 virus, which caused significant damage on a similar scale as many pandemics in the past. So what exactly is the coronavirus? So the coronavirus, like I said, is a crown-shaped virus. We call it an RNA virus depending on the genetic sequence it has. And it usually is carried in a bat being the primary host. And it has a habit to mutate itself very quickly to affect other intermediary hosts and try to adapt to survive in various circumstances. And this pattern of coronavirus mutating itself seems to be only increasing over the last many years. So as you can see, in 2003, we had the SARS, and then subsequently we had the MERS virus, that is the Middle East respiratory syndrome virus in 2012. And then we had the COVID-2 virus, and some in between we had other veterinary diseases which are documented well in animals about coronavirus, but never really affected humans. But if you could see that every virus had a capacity to infect humans as in the end of the chain, and cause a lot of morbidity and mortality. By meaning of morbidity, I mean a lot of health issues which are significantly debilitating. And a possible suspect or intermediate host for the present SARS-CoV-2 was assumed to be this innocent looking creature called the pangolin. And how was it involved in the whole food cycle of the virus? So I should be discussing about that in the next couple of slides. So like I told you about the MERS-CoV virus, that is the Middle East respiratory syndrome virus, which happened in most of the Middle Eastern countries, where camel rearing and taking care of these arid animals is commoner. And the shepherd was the one who contracted the disease, and most people who contracted the disease had severe respiratory illness associated with bleeding, just like the Ebola virus, and a lot of organ damage, including the kidney, heart, and other things. Okay, and but it did not cause such a devastating effect like the Ebola virus or the present SARS-CoV-2 virus. And most of South Asia that saw this MERS virus that was transmitted was able to contain it, and hence luckily India escaped from the MERS-CoV infection. So with regards to the SARS-CoV virus, the SARS-CoV virus, like I told you, was initially grows in bats as a primary host. Subsequently, it spreads on to other animals, and from these animals, it jumps on to the humans. And from humans, you know how it spreads through the rest of the community as we see it today. Why this virus is taking us by surprise? What is the surprise here is that the SARS-CoV virus seems to be spreading through the community at such a large, such a rapid pace that there doesn't seem to be a window of opportunity for healthcare policymakers to understand the virus and try to prevent it in the initial days. And hence, it took a lot of lives in the initial couple of months. And then subsequently, once we started to understand the dynamics of the virus, we understood how to play around with the various ways in which we can control the virus. So what we must understand as a community and what lies in collective responsibility is what is of importance in this present topic I'm discussing. So as you can see here in this particular image which I'm showing you, if there is a naive population and you put one person who is infected with the SARS-CoV virus in the population, how many more people are going to get infected? This is what is called as a basic reproduction number. So I will not go in getting into the medical jargon or the epidemiological jargon, primarily because it is difficult to understand. What I'm trying to enlighten you about here is how a person can be to the rest of the population. So as you can see here, right in the middle, this SARS virus affects about 3.5 people, whereas the COVID-19 virus affects about 2.5 people. So its basic reproduction number is that one person can infect about 2.5 people in the community when put into a community which is naive or not exposed to the virus before. And subsequently, like I said, the domino effect, each person goes on to infect another 2.5 people, and this keeps multiplying at a large rate. Now, what implication do these numbers have on the general immunity of the population against the virus? So let's discuss about that in the future slides. So now that we know that a person can infect another person, how can we prevent the SARS virus from jumping from one person to another person? It's very simple. It depends on the distance you're able to sneeze, cough, or even while talking. So the usual distance that we say is about 6 feet, right? So if you're standing 6 feet away from a person, the chances of you acquiring an infection from a person who's infected, though he might not show signs and symptoms of infection, and we call them asymptomatic carriers, which is quite surprising for this disease because many of its predecessor virus never had a lot of asymptomatic cases. And so if you're standing about 6 feet away, the chances of you getting the infection is far negligible. So how does, and this standing away 6 feet is termed as social distancing. So if you look at this slide, on day one, if you're going to follow social distancing, one person carrying the virus would at max infect about another person. And on 5th day, you would see that that person would infect another one person. And by 30 days, you would infect only 3 people. Now, this formed the concept of the whole social lockdown we had to prevent people from gathering in large places and preventing them from infecting one person to another person, and hence overburdening our healthcare system. And this is what was called flattening the wave. Okay, so similarly, we also saw that if people don't follow their social distancing measures, as it happened in many developed as well as developed countries, by the 30th day, you would have that single person infect another 406 people, which is quite monumental in number. And you can imagine 10% of these people getting admitted in the hospital. That's quite a large number of people that we are already admitting. So if you see that this image shows that as a person coughs or sneezes, or even an activity of singing or talking out loud, the droplets traverse a distance, and you can see that the larger droplets immediately plummet to the ground and land on the ground, whereas the smaller droplets are kind of carried in the air forward and may infect another nearby person. So like I said, social distancing, 6 feet or 2 meters. Many times I've been asked this question, what is the importance of social distancing? And how can social distancing be adapted at workplace? So this is an importance, especially at places for people who don't have to go to their workplace. I deem them lucky. For people who inevitably have to go to their workplace, social distancing guidelines at work suggest that you have to avoid in-person meetings to the maximum level possible. And if it is an unavoidable meeting, obviously you're going to keep a social distance. Eliminate unnecessary travel, which goes without saying. And do not congregate in work rooms, lunch rooms. Bring your lunch from home, eat it at your own desk. Try to use public transportation, try to avoid public transportation system, try to use your own car, try to walk to work if possible, and other such circumstances. And limit your recreational and leisure activities, because It is a time where the entire community has to take collective efforts to prevent the pandemic from causing a lot of loss of life. See, never before has there been an instance that every one of you will be responsible for the number of deaths that happen in the world around, right? So if each person is going to infect another person, then definitely you might be indirectly contributing to the amount of mortality that is happening in the community. So you got to decide whether you want to be, which side of the coin you want to be on. Either you wear mask and follow social distancing and prevent deaths, or either you're falling on the other side of the coin, causing a lot of damage as well as loss of lives, and that can be quite devastating for the families involved. So everyone matters, right? So some people have asked me, doctor, I don't have this infection. I don't seem to have signs of the infection like fever, cough, breathlessness. Why do I even wear a mask? So if you see, if a COVID-19 carrier is wearing a mask and the person who's near him is not wearing the mask and the person near him is wearing the mask, the percentage of possibility of transmission of the virus is to the tune of about 70%. Now imagine the COVID-19 carrier who might be even asymptomatic and not showing up signs of cough, fever, and breathlessness is standing next to a person who is a susceptible person, then the chances of the infection spreading is about 5%. So it's cut down significantly. Now, if both of them are wearing masks, you see that the amount of contagion probability plummets to 1.5%. So even though you don't have the infection, you must wear the mask. And like I showed you in the previous images, if many of you have traveled through Southeast Asia and you have been through the mass rapid transport systems, you would see that a lot of people usually still wear masks much before the COVID pandemic hit them. So this is primarily because of a psychosociological effect that happened because of the troubles they went through with their previous pandemics as well as epidemics that has caused more or less a psychological scar in them. And they tend to be more protective and overtly conscious about going out into the surrounding without a mask, right? And hence even I dream of a day where I can take off a mask. But nowadays, after so many months of wearing a mask, I feel quite sometimes uncomfortable when I take my mask off. So does everyone need a mask now? Yes. Why? Because if you see, anybody who has symptoms is obviously contagious and has to be kept away. Now, what if you are having no symptoms at all, but you are highly contagious? Then you can see that you are that one small joint in the entire chain that can disrupt the whole thing. So if you wear a mask, even though you might not be infected, but there's a high chance you are exposed to somebody in the family who was infected, then you save all the lives that come after you, right? So that is why everybody wears a mask. Now, the third important principle to keep yourself safe is about washing your hands. So how do you sanitize yourself, right? So this is a very basic thing. It might seem silly when I'm talking about how to wash your hands, but it is very important because many a times we forget to wash all the surfaces of the hands, and there might be some hidden areas which can act as a transfer of contagion from one person to another person. And more so, we have been following this in the medical community for a long time, right? How? Because way back, somewhere in the 80s, we found that a lot of pregnant women were dying. And why were they dying? They were dying because of something as simple as a contaminant infection. So if one pregnant woman had an infection and the doctor touched her and he went on to the next pregnant woman, then the other pregnant woman had the infection and subsequently succumbed to the illness. So to prevent this, a basic idea was to wash their hands in between the patients. And mind you, this saved thousands and thousands of lives. Okay, so washing your hands might sound simple, but it can definitely save lives. So the first part is to wash palm to palm, then in between your fingers, then the back of the hands, of course, the base of the thumb, like I'm showing you, and then your back of your fingers, your fingernails, not to forget, your wrist, and then you rinse and wipe dry, right? So the prevention of COVID basically can be, summarized with this present mnemonic called wash up. So what does W stand for? Wash your hands with soap. So you can just have to wash your hands with a normal soap or Dettol, whatever you would prefer. Avoid contact with sick people. Sanitize frequently touch surfaces. Stay there at home if you're sick, and use your tissue or elbow to cover your cough or sneeze, and put your hands down away from your eyes and nose and mouth. So I'm going on to the next slide. Mr. Rajkumar told me don't use a lot of medical jargon because you will confuse them. So I basically have a formula here, but the reason I'm showing you the formula presently here is because I'm going to stick that R0 number here into this complex formula. Forget about the formula. But what this basically shows us is there is a concept which some people keep asking me. And what is that? That's called herd immunity. So what is herd immunity? It is an indirect protection conferred by an immune individual to those who are not immune in the population where the viral disease is causing havoc. So on an average, if you are not immune or you don't have the infection, and a lot of people in your surrounding have had the infection, then assuming that if 67% of the population in which you are has had the infection, you will indirectly gain immunity to the infection. This is called herd immunity. And there were many such gurus in the past who claimed that if the virus is allowed to spread in the community, then maybe 67% of the population will develop the infection, develop an immunity, but they didn't see what lies behind the projection of herd immunity as a plausible concept. In fact, I strongly am against of letting the virus spread in the community and allowing that to develop herd immunity, primarily because, see, as a country, we are about 1.3 billion strong. And assuming that the virus kills 3.5% of the people who are infected, you will need about 87 million people to be infected by the virus to get a herd immunity. And you will be losing almost 30 lakh people to gain herd immunity, right? So this is no way a plausible concept, but herd immunity can definitely be acquired by another way, and that is by vaccination. So how do we, and that is why the whole world, as you can see, is rushing in this present race to develop various vaccines that can bring about curtailing this infection on a large scale. So I should talk to you about vaccines in detail. Now, the second reason why herd immunity is not plausible is because the probability of reinfection due to mutation is always there. So we have already been seeing some cases in the community. There is nothing to scare you, but there are very, very few cases in the community, still not proven, who can be, a reinfection. So I've seen about, for the last, 1 year, we've been seeing these cases. I've seen about 1,500 cases. There's hardly about 5 or 10 reinfection cases that we have come across. And then there were another group of people who put forth the hypothesis of an immunity certificate. Again, this was a stupid idea to come about, because what they said was, okay, if you had coronavirus infection, you will develop antibody against it. And then we will give you a passport called as an immunity passport, which you can, take it and travel to the rest of the world or use it to go to your work. Now, the WHO says we are against the use. Be it whatsoever the various critique that the WHO has received because of the way it is functioning. I must say that this is the only binding organization that the world can look up to at the present moment. And of course, it has experts. So we must be listening to them. And there is no evidence as of April 24, 2020 that antibodies provide protection against subsequent infections. In fact, we've seen that a lot of data shown that in 3 months' time, your immunity starts to wane again. And that has been the challenge for the vaccines as well. You know, if you give a vaccine to a person, does the immunity he develop be long lasting, or it is only going to last for some time and he needs to be revaccinated? So this is another question which a lot of people ask us. And now that the vaccines are going warp speed, I don't think we really have an answer to understand whether this is plausible. Now, these require laboratory tests to validate whether the person has built antibodies or not. And more so, you are basically pushing poor people who don't have the infection to dive into the swimming pool full of infections to basically make sure that he goes and works, you know, to make a meals meet by, you know, promoting the concept of immunity certificate. So get over the infection, get your infection fast, get over it, build your immunity. But what you're not telling him is that it can be catastrophic. He might even lose his life. So I think this immunity certificate is not a valid concept. So what does a COVID infection feel like? So I think by now, from what I see, most of the families have at least 1 or 2 people in the family, or at least their near and dear ones, who've gone through the COVID infection. So it is not very simple to understand what are the symptoms of COVID infection. The typical symptoms of COVID-19 are fever, dry cough, fatigue, of course. Sometimes you have the sputum production, shortness of breath, myalgia, or what is that is called body ache, sore throat, headache. And the rest of the symptoms are, you know, quite rare. But there is a subset of COVID that can present typically like a gastroenteritis. So we have seen a couple of patients come in primarily with abdominal pain, fever, vomiting, diarrhea, and these patients also we must concentrate on. And this is not just common for COVID. If you see most viral infections which are airborne, they either have respiratory symptoms or GI symptoms because of their port of entry. Now, Mr. Rajkumar told me to cover this aspect in detail because there were a lot of questions with regards to testing. Okay. Now, what are the various types of tests the person who has the present symptoms when he goes to a flu clinic or a fever clinic gets subjected to? So we have something called as an antigen test, which is being increasingly used primarily because the turnaround time for the antigen test is quite short. Within an hour, you have your report. But unfortunately, the antigen test is not as sensitive or as specific as a confirmatory test, which is the routine RT-PCR, as we call it. Okay, I don't want to expand RT-PCR, basically called polymerase chain reaction. I leave it at that. It is a way in which we detect the genetic sequence of the virus. Okay. Now, with regards to the antigen test, it is a nasal swab. So what the laboratory technician will be doing is he will put a swab down your nose and turn it around gradually till it reaches the throat and then pull it off. Okay. It is not a very painful test like shown in many videos and you have seen. It is a very simple test. It might cause a little bit of irritation and cough, and that's about it. There is no need to be apprehensive about the test. The second test is a test called as an RT-PCR. Now the RT-PCR forms the lifeline of our triaging capacity in any hospital or large medical establishments to triage the patient as COVID or non-COVID, right? So because the RT-PCR has a sensitivity and higher specificity, but unfortunately the RT-PCR falls short to be the gold standard. Why? Because the RT-PCR is only sensitive in 70% of the patients. Unfortunately, this is the best gold standard we can get for the COVID in the present scenario. So I have had patients who have had their RT-PCR, repeated every third day, almost 4 to 5 times until they were confirmed with the COVID infection. So that itself shows that the RT-PCR can miss the infection. So what is the gold standard? We have to culture the virus. Unfortunately, culturing virus is a very complicated process. It is only done at very complex laboratories like the National Institute of Virology and other things, where they want to study the serotypes and other factors to develop the vaccine. I will not get into the details of such things. What is the antibody test? So anybody who's developed the infection comes to me and says, doctor, I want to get myself tested because I want to know whether I'm immune to the present infection. So I would usually suggest that you get an antibody test done 1 month down the lane to see whether you have developed two types of antibiotics. One is called as the IgG and the other one is called as a IgM. So IgM is an immediate antibody response to clear off the virus, and IgG is the long lasting, or we call it the memory antibodies. And this is what matters. So if you have IgG for a longer duration of time, your chances of preventing yourself from getting a reinfection is higher, much higher, right? So these are the various tests that we deal with. Now, there are some patients who have been initially tested positive who want to retest themselves. So my theory is, you don't get yourself tested unless your workspace demands you to get tested, or there are other various policies in place, various organizations that say, no, you get tested. Like, for example, healthcare workers like us, they would prefer us to be tested because of various medical legal aspects after an infection. So the ideal day to get tested is usually 21 days after the onset of symptoms. Now, unfortunately, there have been a large number of data that suggests that viral shedding continues to happen up till 3 months. So we have had patients I've been sequentially testing for 3 months. And what it does is, we are so protocolized that, the BBMP tests a person who has infection, he is positive, they put him into a room and say shut him off for 14 days. Then they let him out and the person goes and gets another test done. Then he comes positive again. That triggers a BBMP. So the BBMP mechanically working at this level comes back and says, okay, you get extend for another 15 days. So you understand? So since we are highly protocolized ourselves, we might land up in problems with respect to what psychosocial effects it can have on the patient. Like staying in a room for 14 days is not very simple. And people who have already been through it, I know that there were, many people sitting here, some of you might have already gone through the infection. And it is not very easy. It has a lot of mental and physical bearing on your health, which can affect further recovery. So the virus is called a disruptor, not even in a negative sense, not only in a negative sense. There are a lot of positive things we can look forward to. Never in my life I realized, after a lot of clinical examination on patient and how it is very important in our day-to-day medical practice, that I'll be sitting before a computer to see my patients every day. So what was the disruption is that we had to triage these patients without coming in contact with the patients. So the various boards and all over the world, we very quickly, the prime institutes that governs ethical practice of medicine in various countries came about protocols to formulate policies for something called as the telemedicine. So the convenience the telemedicine has given us is astounding. In fact, to tell you, I'm sitting here in Bangalore and seeing patients in Jammu, Kashmir and Bihar and other remote places, and people who are not very confident in the local, healthcare systems. And we have also been able to deliver promising results. Okay, so we classify these patients basically as a low risk patient and a high risk patient. So basically, you would have heard a lot of doctors telling you monitor your oxygen levels every day, measure your temperature every day. And if your oxygen level goes below 94, that is the time when it has to raise a red flag that you have to walk into the hospital to seek care immediately, right? Now, just like I showed you other screening methods for identifying the infection, this is something that you would have time and heard again. Some doctor told me to, do a CT scan. Is it advisable? There's a lot of radiation exposure and other things. So many a times it is seen that the sensitivity or the way in which the CT scan picks up the infection is far better than the gold standard, so-called gold standard RT-PCR. So what we do is sometimes use the CT scan as a screening modality. So suppose somebody has fever and your RT-PCR comes negative, but still you think that the person has COVID, your doctor will ultimately tell you to go ahead and have a CT scan. And the CT scan will show these, if you can see there, those white patches in that black background in the lungs on both sides. The big, fat, white blob that is sitting in the center is the heart. Many people, point to that and say, sir, that is abnormal, sir. No, that is not abnormal. That is your heart. So those white patches which sit in the periphery is the pneumonia. So now that is indicative of a COVID-19 pneumonia. And we score the pneumonia. So depending on the severity, the doctor has, various things and plans to treat the infection. So now we have to identify people at risk. So this, why I'm telling you is, a lot of people throw it under the carpet, right? So they don't really want to face the point because of various factors. It is just a flu, I can overcome it. But you should understand that COVID-19 is not just a flu. So anybody who's above 65 years of age, who has a chronic lung disease like asthma or COPD, has serious heart disease conditions in the past, is immunocompromised, like for example, cancer people who are receiving the chemotherapy, or there are other people who are receiving, immunosuppressants over longer durations that puts their immunity at a, back footing to fight the infection. People who have diabetes, like, India is already the diabetic capital of the world. So this point is very relevant for us. People who are obese, we see, tend to do much worse than people who maintain their ideal body weight. Now, what are the medicines? So a lot of things are coming out in the media. You see that every other month there is a drug race. The various pharmas are having opportunities to push their drug into the market and repurpose. So what is repurpose is some drug which was used for some other reason had to be finally made to use in this present current scenario to target the virus, assuming that the virus has similar targets, right? But most of these drugs have failed to show any benefit in our day-to-day clinical practice. If I have to say in the Indian scenario, if I can name only two drugs, one is the remdesivir, right? So I think most of you are aware of the remdesivir. So if you have a sick patient and the patient is gone into the hospital and his oxygen levels is low, then invariably your doctor will start the patient on remdesivir. A second important drug which we usually start is something called as a steroid or a dexamethasone. Now there is a lot of belief in the general community that steroids are bad for infections. Very obvious, isn't it? Steroids and infections don't fit with each other. So by giving steroids, what we are trying to do is reduce the collateral damage. So what happens is the virus goes and sits in your lungs, then it starts to multiply itself, then it spews a lot of inflammation, basically as a collateral damage, and that inflammation is what finally kills the patient, right? So now we have to bring down that collateral damage by reducing the exaggerated response by your body to something that is as small as a virus, which you cannot see in a microscope. So how do you do that? You push the body in with steroids, which reduces the inflammation and prevents further scarring and other, post-COVID debilitating conditions, which you're increasingly hearing in the last 6 months of the pandemic. Then we have the famous, Trump medicine called the Regeneron, which is nothing but, artificially produced antibodies against the COVID virus. Now, unfortunately, we don't have access to this, but this is again a promising drug that has shown to reduce the span of recovery. So mind you, from all these drugs I've shown you, you must understand one concept. None of these drugs cures the body of the virus. These drugs, any drug in a viral infection, only shortens the duration of illness, right? By shortening the duration of illness, two things. You're preventing the person from developing secondary infections because the amount of time he is with low immunity is reduced. And you're also preventing the collateral damage the virus causes and scarring and other factors that come into causing significant, debilitating conditions in the future. This is one important aspect which I would like to teach all my viewers, and this is called as a prone ventilation. Okay, it's very simple, doesn't look complex. Forget about the tubing that guy is wearing and mask he's wearing on his face. If at all somebody has a bad infection and your doctor has told you that your CT score is very high and you're staying at home, the easiest thing you can do by staying at home is to sleep in different positions, right? So for half an hour, you sleep on your tummy. For another half an hour, you sleep on your right side. For another half an hour, you sleep on your left side, and then you sleep on your back. Okay, so basically you roll yourself like a cement drum, right? By doing that, what do? You're shifting the fluid or the phlegm that has built up in your lungs so that it does not stagnate and become as thick as cement. That is what we call ARDS in medical terminologies. And if you land up in ARDS, there is a high chance you go onto the ventilator. And if you go onto the ventilator, it is seen that in COVID-19, the diagnosis is not, I'm not going to give you numbers, I'm not here to scare you, but the prognosis is not good if you go onto the ventilator. But yes, there are a lot of people still surviving the ventilator. So by doing things like this earlier on in the infection process, you are basically saving yourself from going into the ventilator. A very important aspect is caregivers. So many people talk about the patient, they forget that there are some people who are taking care of the patient who has not even still been infected, right? So you should ensure that the person who is taking care of the patient also receives sufficient care. And that person must follow the various hygiene that we have already spoken about, hand hygiene, mask, and you should also make sure that the patient is given medications correctly in due time, not to be ignorant of the patient's both mental as well as physical needs, right? And also make sure you monitor his oxygen levels very frequently. Monitoring oxygen is one of the most key aspects of managing COVID patients at home. And make sure all the waste products of the patient are discarded separately, right? It's very important because these are called infectious waste. We're used to managing these kind of scenarios in the hospital, but at home, we have to adapt to this new age scenario. And then you're washing off the dish and other utensils separately with soap and water, right? And suppose you get ill, you don't continue to provide care to the person you are taking care of. Make sure that you go and take care of yourself as well, because otherwise it is going to cause problems for you. Now we are coming to the, I was talking to you about the relevance of this topic and why it is relevant in the present scenario. So now we are headed for something called as a second wave, right? So I think Mr. Rajkumar has given me an opportunity to teach you guys some important aspects or learnings of our previous wave that we can put to use, better put to use in the present wave. If at all, we are already seeing Mumbai headed that way, Delhi headed that way. Most probability, I am no soothsayer, but most probably there is a second wave that might come like the rest of the world sometime in late December or January, depending on the scenario, right? So are we prepared for that? And if it comes, it is going to be more devastating and much bigger strain on healthcare. Okay. Now the picture I showed you in first, me wearing the suit, that was a time when it was literally exhausting. I had to take care of, mind you, 70 patients, finish their rounds and talk to 70 people every day to finish off my rounds, right? Apart from the routine work which we have. So it's quite a significant strain on healthcare. Now, as already you're seeing, Spain is showing a big spike and causing significant amount of damage in the form of lives lost as well as morbidity. And rest of Europe has already slipped into the second wave, and they're already declaring repeated shutdowns again. And we are also closing our borders to international travel. So let me come to the last and most important aspect, the only hope, right? So in the armamentarium, which I'm talking about, if there is something that I can vouch for, or if there is something that I can only believe in that is going to bring the end of this deadly disease, it is the vaccine. Now, the SARS-CoV-2 genetic sequence was nothing new, thanks to the Chinese fellows. We can blame them for so many more things, but the genetic sequence was already put onto a consortium or a coalition for epidemic preparedness initiative, a platform on 11th of January 2020, which gives us access for developing various targeted therapy towards the virus, right? So this triggered a race for a vaccine development right from January, which is quite heartwarming because a lot of pharma companies came forward to fight the pandemic at surprisingly short amount of time they took to develop these vaccines, as well as the amount of things they had to go through, various protocols they had to follow, everything being done in the right way to deliver a vaccine that has least side effects, but not but the least has a significant effect on immunity. Now, the first COVID-19 vaccine candidate entered human trials on 16th March. This is the Moderna trial, like we know, which started in Washington. As of today, there's still about 115 candidate vaccines, and about 78 are active. So everybody is trying his luck. But we already know that there are some of these vaccine candidates that are already come into market, and very soon, by the end of December, will hit most of America, and sometime very early next year we should have it, and we should understand who's going to get vaccinated first. Now, you people might be hearing about a lot of things like what are the various phases of the clinical trials that we go through. Of course, the first phase is preclinical, and then we go into phase 1 where a small number of volunteers are tested. Then there is a large phase 2 where 100 or more number of volunteers are tested, and then there is phase 3. Now, most of the vaccines which you're seeing in news recently have already finished phase 3, and very soon they should be entering market. But there's still something left. We're still the last guinea pigs in the race. This is called as a phase 4 study. The phase 4 study, if at all the vaccine in circulation in the population throws up some unwanted side effect, it might get withdrawn also. So we do not know about it, right? Now, who are going to receive the vaccine? Most importantly, the vaccine will be given to people at the front line, obviously the healthcare workers and other people who are in immediate caretaking, who don't have the infection, but who have a high chance of developing the infection. And the second most vulnerable group is the elderly people above 65 years, and the rest of the vulnerable group, which I have discussed in the high risk category. So what does it mean by vaccine efficacy? The other day, there is a race. So Moderna said I'm 95% effective. The Pfizer vaccine said that I am 90% effective. Oxford vaccine said 70% vaccine effective. And then we all went, oh, okay, Oxford is only 70% effective. Is it really going to be the ideal vaccine for my country? Is it really going to confer the best immunity I can get, right? Now, most likely we might get the Oxford vaccine. Now, assuming that I told you that 70%, or I like the number I calculated in the first, if you remember that slide, I said if 68% of us develop herd immunity, then more likely that the rest of the population will have indirect immunity to the virus. So if the Oxford vaccine is 70% effective, now this is an excellent vaccine, because if 70% of the population has effective antibodies against the virus, then the rest of us are automatically protected from the virus infection. Now, these are the various vaccines. As you can see, we have the Oxford vaccine, we have the Pfizer vaccine, we have the Moderna vaccine, and then you have the Sputnik 5 and the Chinese vaccine. And these are the vaccines that are soon going to be coming into market and being trialed into the rest of the vulnerable population, so that it can confer immunity. So with this, I would like to end my talk on the COVID-19 and how to breathe our way out of this present pandemic. I hope I have done justice to the present topic, and I'm happy to take questions if you have any. Thank you, Mr. Raj.
Thank you. This is really simple language that you have used for all of us. We have understood almost every word that you have used. I'll straight away go to the chat portion where there is a comment by, I think, Jyoti. I don't know who this is. Awesome presentation. Thank you, Dr. Srivatsa. My question is, how do you ensure that you are safe and careful? I think you answered it, but if you'd like to add to your comments to this, you please go ahead.
Okay. So when I say that, how do you ensure that a person is safe and careful? If I'm talking about myself as a healthcare worker, then we have various protocols in place. One thing is we wear certain specified masks that are filtering off these viruses. You would have heard of the N95 masks, and then we have much other finer filters like the N100. The details on specifics of which I would not go into. And then definitely we wear a complete suit, a body suit, to prevent various surfaces from coming in contact with the viral infection, and so that we don't spread the infection from one person to another person by contact, right? So not only there is airborne transmission, we must understand, there is also contact transmission, right? So that contact transmission basically by hand washing and wearing specific clothing while you enter the ward. Now, with regards to patient and family members, obviously, people who are in immediate vicinity of the patient have to wear an N95 mask, right? And they also have to wear certain gloves, you know, the normal simple surgical gloves which you get at your pharmaceutical stores is more than sufficient for handling patient waste, patient clothes, and other things. The one important point I forgot to tell you, which is might be a question which people would want to ask: how do you wash this patient's clothing? Right? It's a very simple thing, but yes, I forgot to answer that. So you put your patient's clothing into the washing machine, turn on the temperature to 60 degrees, and do the routine wash, right? And that should kill most of your viruses. So this is how you wash the patient's clothing, and rest of the things I think I have covered in the patient caregiver slide.
Yeah, thank you. That I hope answers the question. Dr. Srivatsa, if you don't mind, you're on screen sharing mode. Can you come out of it? And whoever is attending now, if you have any question, please unmute yourself and go ahead and, or any comment also, please unmute yourself and go ahead and say whatever you want.
Doctor, can you hear me, doctor?
Yes, Ajay, go ahead.
Good evening. I'm Ajay Tandon here.
Yeah.
I just want to know, you said something about oxygen level being below 94.
Yes.
I'm a little confused here because I heard if it's below 90, then it's then you have to worry. You said below 94. I'm just want to know what's the right number to be.
Sure. So if you're below 94, the first thing is don't get worried. Why I say 94 is a ballpark number at which time you seek healthcare intervention, right? Now, suppose you go at 94 to the doctor, there are various other tests the doctor will do on you to classify you whether you're having a mild disease, moderate disease, or a severe disease. Now, only after that, the doctor will take a call on what kind of treatment you receive, right? But if your oxygen levels are somewhere between, below 90, well below 90, then definitely you can assume that you have a severe disease. Yeah? And that definitely requires 100% hospitalization and also requires medications to be delivered at the hospital. If you see all these medicines which I spoke to you about, most of the medicines which are actually working are IV medicines which cannot be delivered at home. It has to be delivered under the nose of a doctor at a healthcare setup.
Another thing, the symptoms which you showed us, the loss of smell and taste was not mentioned. I mean, is it? I just want to know.
Sorry, I didn't look into that. Yes, you're very true. That is a very important question and a very important concern that most of my patients have. Okay, so this loss of smell and taste is very common in patients who have COVID-19 infections. And why is it so common is because the virus enters through a portal called ACE receptors, which are very much needed to look, smell or taste a substance. So because that portal is damaged, you lose your smell and taste for some time, right? Now, most of the time, the smell and taste recovers within a span of 2 weeks. Whereas I do have patients who have lost their taste and smell for a month or more, but ultimately it does come back to normalcy. But it's quite a hard thing, you're not even able to smell what you're eating on a day-to-day basis. So it becomes quite a hard thing to go through that. Yes.
So now, see, I'm talking about the masks which you said we have been using pure cotton masks, double layered.
Yes.
So, what is the, on a daily basis? So,
Yeah.
what
Okay.
is the right?
So now the WHO initially released this policy, and the rest of the even our government said that people wear normal cloth mask, whereas only the healthcare workers will wear N95 mask. The reason being, they found it increasingly difficult to match up the scale of production of N95 masks to cover such a big population. See, literally the entire population is running after N95 masks. And that would consequently lead to shortage of supply to the healthcare workers who are on the front line, or people who are actually having the infection. So to curtail that, they said that you wear the cloth mask. Now, how effective is a cloth mask as compared to an N95 mask? A double layer cloth mask, if you are at a distance of 6 feet, is highly effective. And the other image which I showed you, where I said that the transmission from a person to person, if both of them wear masks, right? If both of them wear a cloth mask, jumps down to almost 1.5% is based on a cloth mask, not a N95 mask. By N95 mask, you are trying to filter out 95% of the particles which can just walk into your regular cloth mask. So the N95 mask is only required in special circumstances. So I don't think I will suggest even now for people to go around wearing N95 mask. But if you have access to an N95 mask, please use it. It's not an issue.
Thank you, doctor. Thank you.
Anybody else has any comment or question? Please unmute yourself and go ahead. Otherwise, I'll ask. Anybody else? Somebody has unmuted. Beena Singh. Any question? Okay, until somebody comes up, Dr. Srivatsa, I would like to know, once a patient has been found to be positive, and then after a few days, he says he's fine. I know you did touch upon this, but then I would like to know specifically, after how long without testing can he be considered to be non-infective? And B, with testing, after how many days can the testing be done?
Okay, so but by most data which we have, which says that if a patient is infected for about 21 days, there is a chance that he might communicate to another person, right? So I would go to B first. So if you want to get away without testing, that would be the most ideal scenario. So a lot of patients who are leaving my hospital ask me, should I get retested? I say, please don't, because it only adds more mental agony and impatience when you get tested positive again. Even though you might have a test that says positive at the end of 3 weeks or 21 days, you must understand what is its implication. The RT-PCR is a test designed to basically diagnose the viral genetic particle. It doesn't tell you whether the virus is dead or alive. So most scientists believe that after 21 days the virus is dead if you have recovered from it completely, right? So very unlikely to a large extent. Obviously, medicine is not exact science. We always talk on probabilities. So there's a greater than 95% chance that you might not communicate the infection from one person to another person.
Okay. There's one more question. Recently in the media, we have read that I think WHO or some other organization has said remdesivir is not to be used. I'm
Correct.
a little confused.
Correct. So this is another, debate that is ongoing. Everybody has opinions. So one such opinion is this, where you have a drug that on ground zero has proven to show good beneficial results, whereas in a very flawed study, I would call it flawed because if you go through the solidarity trial, the trial was called solidarity trial. If you go through that in detail, you would see that they had a lot of pitfalls in which the way the trial was conducted, and hence they came to an inference that remdesivir might not work, right? But most of the medical community and the critical care units around the world still continue to use remdesivir and vouch for remdesivir. And remdesivir still continues to be the main drug which we use against coronavirus until any other newer drugs come.
Okay. We have another 4 minutes. If anybody wants to say anything, please go ahead.
What is this false negative and false positive? I mean, it's so damn confusing.
So false negative, false positive are all statistical terminologies for any test. Okay. So now if you have a test that is going to suppose there are 100 people. Suppose there are 100 people who have to be diagnosed of a particular infection. And I run in through the test, right? Now, to what extent the test will diagnose most of the people is called as sensitivity. To what extent the test will diagnose the people who has the infection alone and only the infection is called as specificity. Now we are working on these two variables. So in simple terminologies, a false negative means that a person has the infection. You test him, but the test is negative. Now that is the most catastrophic thing to happen, isn't it? Because you have a test. Doesn't make sense, correct?
Yeah.
So if you're having a screening test with high false negativity, then it's not a screening test, right? So what they do, that way we supplement ourselves with many tests. That's why I said first we do the antigen test, then we do the RT-PCR, then we have a CT scan. So you push up the sensitivity. Okay, but the CT scan is highly sensitive. That is, its false negative rate is very low, but it is not specific. If I find a shadow like that on the CT scan, it might not always indicate it is corona. It can happen in other viral infections. It can happen in other kinds of lung inflammatory syndromes. It does not mean always corona. So that is false negative. Now with regards to false positivity, that is, patient does not have infection. You test him, but it is positive. Now that is only going to cause more mental agony to the patient, unneeded isolation, all those. But most good tests have a very, very, very minute possibility of showing false positivity. But there is a scenario which Mr. Rajkumar discussed. I am infected, 3 weeks, I test. That you can classify it if need be under false positive. Though he is not infected, he is still carrying the viral RNA, and hence, he is falsely positive. He is falsely positive.
Wouldn't it be simpler? You have it or you don't have it. No, I'm saying either you're negative or positive.
Correct. So the thing about this is why I said that you see, medicine is not exact science. So we never have 1 + 1 is equal to 2 in medicine.
Exactly.
So
1.5 also, you're right.
Correct. So that is
now,
the thing. So,
if you don't mind,
sure.
Kishorji, please go ahead quickly.
Yeah. Yes. When you get the good evening. When you get the test, in the RT test report, there is some numbers given like 60,
CT score.
70.
Yeah, correct. So never depend on the CT score, because the CT score doesn't imply how bad your disease is. So a lot of patients ask me, my CT score is 40. Does that mean I have a mild infection? My CT score is above 70. Do I have a very bad infection? The CT score has no relevance to the severity of the infection. So I don't think we should be concerned with the numbers. There is a cutoff value. If you cross the cutoff, yes, it's positive. If you're below the cutoff, it is negative.
What is the cutoff, sir?
So the cutoff is usually we use it as around 50.
Okay, quickly, I will name people who I know. Sarita Bhansali, any question? Beena Singh, Aruna Nagaraj, any question, any comment also, please go ahead. We are going to close very soon. Unmute yourself and go ahead. Anybody? Arvind, anything? Somebody speak. Okay, now it is 7:55 and we need to close it because this is only scheduled up to 8 p.m. That is a maximum. I will request Ranjana to go ahead and do the honors of thanking Dr. Srivatsa for a fantastic,
yeah, sure. Thank you, Raj. That was an enlightening session on our lungs and the pandemic. I'm sure each one of us is better equipped now to handle the situation. Should you have any further questions, you are free to post these in the comment section of the video, which will be shortly uploaded onto the C4C YouTube channel. And we request Dr. Srivatsa to respond to your queries later. So on behalf of C4C, I thank all the attendees to this educative program for having attended and help in making it a success. On behalf of C4C and all the attendees, I would like to thank Dr. Srivatsa Lokeshwaran for his time and knowledge sharing in simple language. I have attended and I have definitely benefited, and I'm sure all of us have. As Raj said, medical terms are difficult for most of us to understand. Luckily, as far as possible, Dr. Srivatsa has kept it simple. So once again, thank you all, and thank you, Dr. Srivatsa. Wishing all of you good health always. Continue adhering to wearing the suitable mask, maintaining distance with others in public places, as well as washing your hands with soap and water properly. In addition to making use of all the knowledge that you have gained today. Healthy lungs lead to healthy body. Stay healthy, stay safe. You may leave the meeting now. Good night and namaskar.
Thank you. Thank you, Doctor. Good night.
Thank you. Thank you all for the patient hearing, and I must thank C4C for this wonderful opportunity Mr. Rajkumar and rest of the organizers have provided to share this experience as well as various vital points to take you through the rest of the pandemic and come out safe. Take care.